Hello, Jason. Can you hear me?
Yes.
We can see you, we can hear you.
All right, good then. So I'll just quickly try and see my presentation also loads so that there is no, or shall I put one copy with you guys? क्या करें? Try करो.
नहीं, you are in a better shape than us. चलेगा रुको.
क्यों इतना मुलुंड में ज्यादा बारिश है और इधर न्यू बॉम्बे में नहीं, ऐसे थोड़ी है.
का प्रॉब्लम नहीं है, हॉस्पिटल के कॉर्नर में है, उसका प्रॉब्लम है. घर पे वाईफाई नहीं, वाईफाई पे नहीं है, इसलिए यू लुक ऑन वाईफाई.
ओके, चलेगा, ठीक है. All right, I will join back again. Just stop my video. Nice to meet Dr. Ashish. Hi there.
Yeah, hello, Dr. Suresh. Nice to meet you. Yes, welcome.
All
Hey,
right,
Suresh,
sure.
good evening. Oh, he's gone out. Okay. Let him join back. How are you?
Long time.
I know, long time. COVID has kept us all apart.
Abhi idhar you are in different states only, no? Navi Mumbai and South Mumbai, no? Two poles. Jaisal is in between,
Yes.
trying to
Close
be
to
close
both
to
of us.
both of us. Chalo, I'll join back. See.
Nitu, क्या still not working out for you?
So, Ashish, where exactly are you?
So I'm in Pune. My hospital is in Pune city itself.
Okay.
Yeah, Lakshmi Road. Yeah.
Okay. Excellent.
Yeah.
Good.
He is current secretary of Maha.
Yeah. We had
Yes.
we had met for the simulation workshop in New Delhi.
New Delhi, Noida. Yes.
Yeah.
I remember, Ashish. Yeah.
Yes.
It's going good. How's it going over there?
Yeah. Very last month was horrible. I mean, many patients and very busy.
Yeah. But it was strange. Last month we had so much deliveries and so many premature. And this month in September, it's quiet. Suddenly, I don't know why. Last month we hardly had time. And this month, you can relax.
Yeah, correct. It's still.
So I think the August festival season made everybody very happy or God knows what, and they all went into the delivery or God knows what,
I was expecting some rise in patients after Ganpati festival.
Yeah.
And here.
Nitu is there or not?
But the COVID is gone now in Bombay.
Yeah, over here as well. I think very few cases.
The flu has become rampant.
Oh yeah, swine flu. Every other case is swine flu, I think.
And now we don't have to tell patients to take flu vaccine. Now they come and say, please give us flu vaccine. So our job has become easy now.
True. Flu and dengue, I think.
Yeah, flu and dengue.
Yes, madam, I've joined again. Just see if the slides are moving again or not.
So till then I'll quickly.
Yeah, we can start.
Yeah, I'll just start the program. So
can we just check now?
Yeah. Welcome all the viewers to this webinar. So today we are going to have two important topics related to nursing care. Yeah, we can see it. It's moving also.
It's moving now?
Yes.
Let's
Perfect.
come to the next slide.
Yes. Thank you.
Okay, great.
Yeah, so welcome all viewers. So today we have nursing topics. So one will be developmentally supportive care, which you will know a great deal from Dr. Neetu Mundra, and she'll be giving you important tips as well as to how developmentally supportive care is carried out in the NICU. And the second topic will be about how to care for central lines like umbilical lines and IV catheters, which is the most important part of daily NICU practice. So because that is going to help you in so many different things like preventing infection and giving the drugs right, lessening the medication errors. So Dr. Jaisal will be introducing the speakers and the expert for today. So Dr. Jaisal, can you please introduce the speakers and expert?
Yeah, it's my tremendous honor, experience, honor and privilege to actually introduce the expert moderators, speakers who are very dear friends of mine. So welcome Dr. Amish Vora. Dr. Amish Vora is a very senior, not very senior, but very senior to me, consultant, neonatologist, pediatric intensivist, pediatric cardiac intensivist, and ECMO specialist. He has been trained in UK and Australia. He had been practicing in UK for many, many years. And since last 7-8 years, he's practicing in South Mumbai. So welcome, Dr. Amish. His CV is extremely long and he has a very keen interest in doing research and is a passionate educator in all the state and national congresses. Welcome, Dr. Suresh. Dr. Suresh is again a very dear friend. Dr. Suresh is a consultant neonatologist. He's practicing in Motherhood Hospital in Navi Mumbai. He has done his pediatric training from India, followed by Australia, and he has done his neonatal training from Australia. And since again last 7-8 years, he's practicing as a consultant neonatologist in Navi Mumbai at Mother Care Hospital. He was previously working in Nanavati Hospital. Dr. Neetu Mudra. Dr. Neetu is a DM neonatologist from a very reputed institute, KEM Hospital. She practiced there as a assistant professor for 2 years, and now she's practicing as a consultant neonatologist in Wockhardt Children's Hospital in Mira Road, Mumbai. So I welcome all of you actually, and I request Dr. Neetu to start your first talk. Dr. Neetu is very passionately actually involved in the developmental care of the neonates. And I think this is a kind of a topic which is very, very close to each one of us who believe in working hard to improve the long-term outcomes. So over to you, Dr. Neetu.
Thank you, madam, for such kind words. At the outset, I will thank all the organizer for inviting me for this topic, which seems very simple, but it is very important for the newborns, because nowadays we don't want just survival, we want an intact survival. And the sisters has the main role in doing that. So we will just go through, the slides may be more lengthy, but we will go through the important topics and important tips which we should be caring about when we are caring the newborn babies. Also, I will thank my mentor, Dr. Ruchi Nanavati madam, because she has always instilled this just to us, ki developmentally supportive care to karna hi hai. So without wasting further time, let's discuss the topic. So I'm good to go. Audio, video, slides.
Yes, please carry on.
So I can see there are already 66 participants, which I know. There are a lot of sisters from all parts of India. So we make this interaction, we make this session more interactive, and I might be asking few questions which you feel free to answer in the chat box. So a bit about history, very short. First incubator was installed in Paris in 1880s, long back. And then we never looked back. More or more sophisticated equipment has come, the technology has advanced, and now we are in 2022, where we have everything we want to take care of the babies, and this modern equipment has come in 1970s and 80s. So this is now the NICU dominated by advanced life supporting system of ever increasing complexity and technology. But developmental care is often regulated as follow-up. Bhai jaan to bachao baad mein dekh lenge. But it's not like that. The concept was that the newborns are unaware of their environment and unable to participate in meaningful interaction is wrong. Now we know that the newborns respond to touch, pain. They have their preference for certain stimuli. Certain stimuli are overwhelming for them. Certain are good for them. They are positive touch. So we know this fact, but what happens? Just imagine a baby is being born at 28 week or 1 kg, and we are welcoming the baby with a torch blade, pipes along with ek haath mein hepatitis B, ek haath mein vitamin K. We have to poke the baby immediately after birth. We have to weigh the baby in the cold weighing scale. We have to establish airway. We have to put trials tube, and a lot of stimuli which goes on at the time of birth, which becomes very, very, very overwhelming for the patient. For the sister, just imagine one scenario. You are sleeping quietly at your home. Acha sa environment, cozy rainy day like this. Lights off, sound, no sounds, and suddenly someone budges up loud music. A few disco lights are there, and then you will be very much like irritated and you will shout, "Band karo." But what happens to the baby? They cannot even respond, ki band karo. So it creates a very much stress, an emotional stress to them, and which is harmful for the development. And it creates problems with the long-term outcome of the baby. This is a normal preterm baby, looks like all will agree. There will be an endotracheal tube. The baby is connected to ventilator, feeding tubes, lines, UVC, UAC, overhead warmer. All the time nurses taking care of the baby, maybe touching every hourly or 2 hourly to look at the vitals. The registrars are coming, the neonatologists are coming, and then we are monitoring the babies. Okay, these are all important. But what we neglect, that we have to take care of equally important thing here, which is the development of the baby. See the change. The baby was in intrauterine environment, right? Can anyone just write what are the things which we have in intrauterine environment and what are the differences when the baby come to outside? I know we have just 25-minute time, so I'm not asking someone to come live and answer, but just try to have this exercise in your mind. Inside the uterus, the baby is supported with the flexed posture, is comfortable body for the baby, content, thermally comfort, shielded from all the lights, protected from sound. There is a good oxygenation going on, protected sleep cycles, and very important, unrestricted access to his mother, which is very calming thing for the baby. And this all positive sensory environment is crucial for normal brain development of the baby. And suddenly there is a birth, maybe a preterm birth, a baby had some stress, and then baby come to a nice environment, which is totally different. We provide a physical environment which is too little for the baby, too much noisy, too much soundy. We do protect from infection, fire. We have professional staffs, sophisticated equipment. We have evidence-based treatment modality, and that's why we have good outcome. But the NICUs are becoming more and more complex. Like the first NICUs, which used to look like this, and now the NICUs look like this. Lots of tubes hanging around, lots of sound buzzing around, lots of people running around, right? And what this leads to? Yes, improved survival, good outcome, but what? Along with that, we have learning difficulties, motor impairment, sometimes cerebral palsies, ophthalmic abnormalities, hearing defect, speech delays, and no one wants to have this in their babies. We don't want our NICU graduate have this kind of morbidities when they are discharged from the NICU. And for that, this is very important that we take care of the babies right from the beginning. So research has shown today that the sensory environment of the young organism has an important influence on the development of sensory system, brain, and behavior. This is a very nice quote which I got done by quoted by Kristen Homan, that the genes are the brick and mortar to build a brain, but the environment is the architect. So we have to make the environment good so that the brain is formed very well. That is the why we need to have developmentally supportive care, and how it is defined as a care of an infant to support positive growth and development while allowing stabilization of physiological and behavior function. So we have to support the positive growth and development, and we meanwhile allow the stabilization of the baby for the behavior and the physiological function. It provides care in a manner in which the environment of the NICU, the light, sound, the physical environment, everything is adjusted and individualized in response to the development and tolerance need of the baby. If it is not clear, you can ask me again. If this baby needs this, we provide this. So this is something called as need cap care also, which we are not going to discuss in detail, but essentially we provide the things which are needed for the baby, and we provide the environment so that the baby's sensory environment is apt for the development of the brain. The interventions which we do in the NICU should also be designed to simulate the intrauterine environment, like doing nesting, giving positive touch, providing KMC, doing non-nutritive sucking, provide swaddling. This all are the positive intervention which we do to support them. We promote the normal neonatal development by doing these interventions. So what are the key aspects? What we do? Number one, you have to identify whether the baby is having in some stress, because they are not going to shout and say, I'm having this stress. We have to identify few features. We have to see them physical or signs to see baby is having some stress. Then we do some environmental manipulations and modifications so that we provide comfort to the baby. We do handling in such a manner, we do some position practices such a manner that it provides support to the baby. There are few NICU interventions which has been evidence proved to help in the development. And bottom of all care in NICU is a family-centered care. We do take care of the parents' need, parents' emotion, and involve them in the care of the baby so that they can also provide this to the baby. So number one component which we discuss is assessment of this stress. At least just see the baby, how the baby is doing. The sign of stress is depending upon, like system wise, we can see respiratory, the baby is having tachypnea, baby's pauses, have irregular breathing. The color is not looking good. The baby sneezes, yawns, have more hiccups, gagging, grunting. There's tremors, the baby startles, the baby twitches, the tone is not good, posture is an inability to maintain a flexed, comfortable posture. Frequent flaying, little movements, the sleeps are restless, the baby is awake, hyper alert, crying, having inconsolable cry, aversions, or the rapid transition from sleeplessness. These are the signs of the stress to the baby. Whereas if we see the baby is very smooth, unlabored breathing, have regular breathing, looking very pink, as smooth digestion, toilet speeds, there are no motor patterns, the baby is maintaining a posture, reliable tone, baby's activities are consistent with the environment provided, have quite restful sleep, is bright, shiny eyes when alert, when sleeps is very comfortable, and there's smooth transition from a state to the other state, that means that the baby is stable. So what our goal is to provide the stability. What we have to identify whether the baby is in stress, and if the baby is in stress, we identify the cause and solve it out. So number one component of developmentally supportive care, we say, is the assessment of the stress. If we don't want to just go through the each and every system, and if you find it is not fitting into the comfort zone, let's find out the problem. If it is not physical, please see if it is stressful or not. And then even you can do the pain scoring, which is, I think the lecture has been taken earlier also. The baby is in pain and the stress, that means we need to improve, and then we go to the further thing. Now the second thing is providing an environment which is good for developmental supportive care. So what are the aspects of the NICU environment? We touch the baby every 2 to 3 hourly. We monitor karna padega. Baby is sick, baby is preterm. We need to monitor. We need to see heart rate, respiratory rate, and everything. But we have to see whether we are clustering all the activities or not. Whether each touch is important for this baby or not. So touch, number one, is the environment, NICU environment, which we need to look at. Like number two, noise. Very common to have loud noises in the NICU. I will tell you what are the noises which we feel ki normal hai. But for the baby, it is very much. It is too loud. Light, smell. How do we handle the babies and how do we manage the pain? This is the second thing which we need to take care of, a nice environment. So we deal with each of them separately. Number third, we will look at the positive positioning, positive intervention analysis, which we have to do. Touch. It's not an uncommon scenario. We are taking a baby to find to collect a blood. We touch the baby 5-6 times in a day to provide feeds, to monitor. So whether we are clustering the events or not, whether this each prick is required or not, can we cluster the pricking? Can we do it and then we do the IV line? This need to be done. So this negative touch, pain, has long-term impact on the baby, because pain pathways are formed at 28 week itself, and it has a long-lasting memory in the brain through in the brain. So they will remember through macrophages actually. So they remember this pain for lifetime. So we have to be very particular about it. Second environment, we need to see the vision. When an infant is born premature, they have not developed their eye and eye vision or retina till now. So retinal development take place in an environment that causes various insult and which may have long-term outcome. Intense direct light or total darkness, both are not good. Absence of adequate light when awake. When the baby is awake, they need adequate light. When the baby is sleeping, they need dim environment. Lack of object and pattern in focus. एक ही जैसा दिखता है. The baby is sleeping in some same cradle, 24/7, looking at the same wall, 24/7. Nothing is changing. No pattern is coming. Even in the NICUs where mother entries are restricted, nothing changes to them, which again have impact on their development. Lack of attentions and sedations when the baby is needed. Lack of change in the environment, lack of movement, and this all causes difficulty in the proper vision development. So what are the required light levels? The ambient lighting below 300 lux should be there, and measuring medications you need just 500 lux. If you need any delicate medical procedure like putting a PICC line, then you may need more lights. But most of the activities in NICUs can be done within 100 to 300 lux. And the recommendation for standard for an NICU is 10 to 600 lux and procedure lighting not more than 1000 to 500. These are the recommendation from the AAP 2009. Coming to the second thing, hearing or the sound effect. You see a lot of ventilator buzzing around. There's a beeping all the time, beep, 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 beep. The patient has to know uska heart chal raha hai, beep, beep, beep. If there are alarms, they buzz at the top of their voice, and the CUG mobile or the mobile of the registrar or the neonatologist going inside rings around, and there are a lot of sounds, even giving over to the patient, to the next incoming batch, giving updates on the patient. This all produces a lot of sound in the environment. And what it leads to, it has a long-term impact on hearing loss and impaired attention and auditory processing. You know what is the in utero sound? It's just 40 to 60 dB. And if you don't know what dB is, like 40 to 60 is just a whispering sound. And anything more than whisper is more than for a baby. The usual level of sounds in an NICU goes above that, which is 52 dB. So baby is used for 40 to 60. And the usual, if you don't even have sounds, extra sound, it is 50 to 80. An IV home alarms around 60 to 80. Pulse ox is around 90. If you tap on the incubator, it is as loud as 100 dB. Bubbling sound of ventilator goes around 60 to 90. So we don't need to mug up this sound, but just have this concept in mind. If the sounds which seems normal to us is very much more for this baby. Jisko 40-60 ki aadat hai, we are giving at times 100. So it is too much for the baby and they may have problems. What are the sources of sound? Is incubator mein they will be peak of around 170s. Additional equipment sound, routine care activities can produce sound, and the alarms can produce sound. And you know, there's a study done by Chang et al. Which they showed there are almost 5,000 peak sounds, and 90% of them are human related. That means what? We can improve this 90% of the thing, and that's why we want to know this thing and improve. Olfaction. So baby was inside, was just having the smell of mother's like in amniotic fluid, and it was very good for the baby. Now it comes out. Pehle line lagaya, chlorhexidine, spirit, betadine. If you smell your hands after putting sterilium, you will feel how pungent it is. And then we put this baby, we put these things on the baby, and then they get overwhelmed with this olfaction also. They are overexposed with the odors of detergent, which we use to wash the clothes of the baby, disinfectants, cosmetic, formulas, and everything, and which is almost too much for the baby. So what we need to do, we know these are the problems. These are overwhelming. They can have long-term impact. So what should we do? Let's discuss the things what we can do, and where all nurses have role in it. And these are very simple measures which we can do for the intact survival, for the better survival, for the better development of the baby. So let's discuss developmentally supportive extrauterine environment. We'll discuss one component each and what we can do. Number one, location and the design of an ICU. It's better to have near to the labor suit so that you don't transfer the baby from one side to another side if visible, which is best. You should have interconnected ways from labor room or OT to the NICU directly. These are the recommendations that you have 120 to 150 square feet per bed, excluding sinks and aisle area. There should be minimum 8 feet distance between two beds so that the you can individualize the care for that baby. Is baby ko kya chahiye, iske liye kya kar rahe hain? We can individualize so that there is a good distance. And sisters ratio should be good enough. It is ideal to have 1:1 ratio for a baby who has intensive care. For a baby who is in step down, you can have at least one nurse for 3-6 babies, at least minimum. More the nurses ratio, more the care can be provided, best it is for the baby. But in developing countries, we have to see the feasibility, but at least 1:1 for intensive care and 1:3 for this. So this is how we can design our NICU. Now coming to the light, we said the light, what we need, 100 to 600 flux, what we said. We said light are often moved. So it is good to have individual lighting for each baby. Her baby ke upar apna light hai. If we need, we lit up that light. If we not, keep it close. All light should be indirect. They cannot be a direct light going on the baby. You are sleeping and you have all time the 3rd degree light on your face. It is not comfortable for us. Leave apart for the babies who have more sensitive light. So indirect light where you have shielding and the light goes up and then reflect back from the shielding. Spatial procedure focus control light. If we are doing any procedure, you have that special spotlight given for that baby. You do that procedure, switch off that light and take it. Light levels not brighter than necessary to complete the task. We should have the smart lights where we can dim the lights when not needed. Whatever if the baby is awake, we have more light. If the baby is sleeping, we dim it. And working area, only the light which should be lit all the time is only the charting and nurses area, which have independent control and should be away from the patient bedside. For a less than 28-week babies, they just need less than 10 lux. This is just, it is just the light needed, light levels of a candle lit room. That is the only light they need. For more than 28 weeks, depending upon the baby's procedure, we just need a typical office light. And if baby is awake, you have more light. If the baby is sleeping, you close the light. And that is called as circadian rhythming of the light, and which helps in maintaining the sleep-wake cycles, rhythming the hormone production, and it is important for the baby's care. Coming to the second thing, what we can. So in short, for light, we have to put individual light for the babies. With the dim the light when the baby sleep, we make spotlight for the procedures, and we keep the light depending upon the gestation of the baby also. If the baby is less than 28, we keep the lights low, right? So it's better to have a preterm room and if feasible, where the lights can be adjusted. If not, at least individual light for each cradle. Coming to the second thing, what we can do, hearing, sound, how can we minimize it? We have all ceiling floor sinks which have absorbent quality, so they absorb the sound, like in the cinema theaters or the drama theaters. Windows can have sound absorbing blinds. You choose your blinds also carefully. Skin to skin holding provides infant access to speech and patterns and the language that brain first registers. So skin to skin contact is also good for the language development. In fact, the use of soft music, Indian classical music, is said to be good for the decrease all possible sources of NICU. What are the human voices of the siren? We don't need beeping all the time, and decrease the monitor noises if not needed. Respond to the alarm quickly. Alarm baj raha, we are not responding to it. Decrease human voice. What is needed for that baby? Rounds and reports away from the bedside. We never used to take a round at the bedside of the baby. We always used to go 3 to 4 feet away from the baby to present the case, and then we go to the baby, examine the baby, and then we come again out to discuss what we can do the case. Speak softly. Decrease telephone and intercom. We should not be allowing mobile inside the NICU itself. Move equipment quietly, train your GDs in that, decrease staff generated noises, prepare medication and feeding away from bedside, gently open doors and drawers, follow the sound limit. Anyone can tell me what is the sound limit in the NICU? Anyone can just answer in the chat box. It is 45 to 50 dB, which is allowed in the NICU, not more than that. And which I said is just the sound of a whispering voice. So not more than that is allowed at bedside. Have a telephone culture always, which is the explosion nowadays. No short burst more than 70 dB is allowed in the NICU. Coming to third thing, olfaction. So we can recreate the original order or ambience of mother using breast milk, or you can use the mother breastfeeds, keep them beside the baby. Katori mein madhya ka milk, you can just keep beside the baby. So mother can even, baby can even feel the presence of mother by this, because she has been exposed to this, she or he is exposed to this smell, and they will feel comfortable about it. Dry your hands completely after taking spirit or disinfectant before touching the baby. Both, number one, strong olfaction. Number two, before it dries, it is not working. So these are the things which we can change in the environment: design, sound, light, olfaction. Coming to some developmentally supportive infant care practices. So we have changed the environment. We do it up now. What practices we can do? Number one, give positive touch to the baby. So position baby in a flexed manner, containment of the baby. If the baby is in pain, swaddle the baby, do the facilitated tucking. Gentle touch. Don't be rough on the baby. Even massage therapies are good, whether recommended in NICU or not. But this was earlier debate whether the infection will all or not. But at least after discharge, they can do massage. Oil massage is recommended if you can maintain in a manner where we do not spread an infection. Oromotor stimulation. You have to train mothers do OMS. Non-nutritive sucking. Put the baby on mother's empty breast if the baby has not developed sucking yet, just to have that non-nutritive sucking. Comfort and swaddle the baby when they are crying. Most importantly, give them skin to skin contact. Practice KMC. Use minimal adhesives. Bade adhesives are not required. Small adhesive, do not put, this is a very common practice. IV nikala, ek adhesive laga ke rakh diya. Why you need adhesive? You have to remove the IV, just put a small cotton, press it. Within like 30 to 60 seconds, blood will stop, and you need not to put that adhesive to the baby. Avoid that extra adhesive, because when you will lift it, the baby will have pain, the baby will be again disturbed. So use minimal adhesive as needed, and properly remove adhesives, applying water and slowly removing it. Use analgesics when required, and when required for the baby. Even you can use EBM swabs for the baby to reduce pain. This is, I have already written, this is just putting a nesting around the baby so they feel very comfortable, they are flexed, they have midline orientation. It mimics like uterus, as a uterus, and baby feels like the baby is still in the uterus. And it gives the positive flexion, the midline orientation, and a feeling of contentment for the baby. Use nesting for the preterm babies, it is very helpful. And it should be, nesting should be properly placed. बच्चे के बगल से नहीं, बच्चा इधर है और nesting एकदम दूर से जा रहा है, it is of no use. Should be properly placed, like you can see here. Provide mother's milk. If the baby is not developed nutrition, you have already told, put the baby on mother's empty breast for providing non-nutritive sucking. We cannot overemphasize the importance of kangaroo mother care. I think we have already had a class on KMC few weeks back. So that was the last thing I wanted to discuss, madam. I think we have discussed on 30 minutes. Now I just want to ask, anyone want to have the questions, or we can just summarize what we have done.
All the questions, answers in the end when Jaisal comes up, and let's go to the next talk. Very well presented, Neetu. And I think we'll go ahead and with the next talk, please. And then in the end, we can take both the question answers together.
Yes, sir. Yes. I just wanted to finish in 20-25 minutes so that we have
Well done.
the next.
Good timekeeping.
So anyone just want to ask any questions, I'm there to answer. Thank you.
Just put the questions in the question box. All the questions in the question box, in the chat box, will be read by Dr. Yesel or me, and then we'll ask the experts to give the panelists to give their answers. Okay, so please put your questions. Don't worry, whatever you think you have any doubt, please put those questions. And don't think any questions are silly. All the questions, any doubts you have will be answered. Okay. Thank you. Thank you, Neetu.
Thank you, sir.
You unmute yourself. You can't unmute yourself. Who's the host? Please unmute doctor, please. Jason. Jason, please unmute. Please unmute Dr. Suresh and then Nurse Lintu, please.
Sir, we are just making Dr. Suresh co-host.
Yeah, Ashish, thank you.
Just one sec. Linu. He has joined as Linu.
Linu.
Yeah. Can you find him? Dr. Suresh, 1 second. He's just doing it.
So while that is going on, I don't see any questions on the chat box, but let me open it again.
Okay, thank you.
Okay, yeah, they've come.
Let me just try to get the PPT. I share screen. Start the share screen. This is what this one. Okay, can you see the PPT?
Yes, sir. Yes.
Okay, so yeah, as you have introduced myself, I'm Dr. Suresh, and this is Linu Matthew, the nursing in charge at NICU Motherhood Hospital. Welcome, Linu. Please start.
Okay. Today we are going to discuss about care of intravenous and central catheters in neonatals. And first we are going to discuss terminologies. A venous access devices in any devices that is inserted into the venous system is a venous access devices. And a peripheral cannula is a short hollow flexible tube placed in a peripheral venous is a peripheral venous cannula. And central venous catheter is a catheter placed within a large central vein. It's a central venous catheter. When placed through a peripheral line, it is called peripherally inserted central catheter or PICC line. This is the PICC line pictures and peripheral line pictures. And UVC. It is a catheter inserted to umbilical vein called umbilical vein catheter. It is a catheter inserted to umbilical artery is called umbilical artery catheter. And what are the importance of IV and neonatal venous catheter in newborns? First one, providing IV fluids and IV antibiotics and providing parental nutrition, especially through central catheters. Or if baby having umbilical venous catheter or central venous catheter, we can reduce repeat attempts for peripheral IV catheter insertions. And this is the most care for peripheral venous cannula. First, most important care bundle. We want to maintain care bundles for peripheral venous cannula and choose correct size of insertion. We all know about availables of cannula sizes. And then preparation. Following 7 steps of hand hygiene and 70% of alcohol sub or chlorhexidine sub. Insertion, we need 2 persons, 1 operator and 1 assistant. And next one is securing IV catheter or fixing with visible taping. Then maintaining patency for peripheral catheter for post-insertion care. This is the care bundle. We want to use every shift. Review need for cannula on daily basis and inspect the cannula or observe the signs of infection and following hand hygiene, 70% of alcohol disinfect and replace the cannula if any phlebitis or redness. We are using VIP for VIP mean visual infusion phlebitis. If patient appear healthy IV cannula, we can give 0 score, or pain redness or around insertion site, we can go to 1 score. And above 1 score, we want to replace the cannula in a new size. This is the size of IV cannula. Pink and blue color IV cannula we are using for central catheters, and mostly we are going to use yellow color 24 kg in neonatals, and premature babies sometimes we are using purple color 26 kg IV cannula. Pre-insertions for cannulas. First one, hand hygiene. I already told 7 steps of hand hygiene and cleaning for 70% of alcohol sub and sterile gloves. These are all the equipments we want to ready for IV catheterizations. How we will the select of site? It should be radially straight vein and should not be bruised and should not be previously pricked one, and no difficult immobilize the joint of the extremities. Insertion. How we will insert the and proper position infant appropriately. Using an appropriate disinfectant, clean the skin thoroughly in circular motion. Serve for at least 30 seconds. Allow to dry. Do not repalpate. Stabilize when and cannula about a 10-degree angle insert and cannula and observe the blood flashback appears. If blood flash appears, remove the stillet and place in a proper container to avoid needle stick injuries. And securing IV. How we will secure the IV? It is the important part. We want to secure the IV with butterfly tapes. I will show you one pictures how we will do butterfly tapes. This is the first pictures. Butterfly taping with sterile strips. And then this second pictures we will visible the tip of the cannula, and it is fixed with flexi-board or splint, and then this is the visible tape we are using, and third pictures we can visible the free fingers. We are using air bundle to prevent this solar complication of IV cannulations. Next topic, what is UAC and UVC used for? Umbilical artery catheterization, umbilical and umbilical venous catheterization used in NICU units as it provide quickly assist the central circulation of premature, tame or sick newborns. Why we are using umbilical artery catheterization? It used for ABG collections and blood sampling or if one continue artery blood pressure monitoring. Umbilical catheterization procedure preparation. First, importance consent. If every procedure we want to do consents and ready for equipments and correct size catheter for insertion. We can avail 3.5 Frenches, 4 French and 5 Frenches. Positions of infant, umbilical tight tape, 7 steps of hand hygiene and aseptic 70% of alcohol swabs. For insertion, we need 3 persons, 1 operator and 2 assistants. Securing umbilical catheter or fixing with transparent Tegada. Maintaining patency of umbilical catheter and monitoring for insertion site infection or blockage, that is a post-insertion care. This we are using sterile umbilical catheterization set, and these instruments all are we using for procedures. This is the items we want to ready before the procedures.
So I will just chip in here, because most of the times these umbilical catheters are put by the doctors with the help of nurses. So wherever we are putting umbilical catheters, after all these preparations from the nurses help, when we have washed and sterile, then we have to grasp the umbilical catheter and gently introduce in the umbilical vein. And the base of the umbilicus has to be firm. Whereas when you are cannulating umbilical artery, always dilate it first by umbilical artery forceps or RS forceps, and then gradually with a sustained pressure, you just push the artery, umbilical artery catheter forwards. And eventually there are various calculations what length or depth you have to insert, and where it should be the tip of the line should be there on the X-ray. So there are various algorithms. There is one with shoulder umbilical length and the other with based on weight. Whichever your institute is comfortable with, you can carry on with these formulas.
Procedure for umbilical catheter insertions. Set out of equipments. Already I told you what all the equipments we need. Observing strict sterile technique. Position infant appropriately, and because avoidance of placing clamps or suture on the skin. Label artery line clearly, because which is umbilical artery catheter or umbilical venous catheter. Connect catheter to infusion fluid. Do not connect inotropic drugs or fluid with high concentration glucose till confirming position on X-ray.
So this point is also very relevant. Why it is important not to directly infuse all these cytotoxic or high dextrose concentration drugs, because if we haven't checked the position of umbilical venous catheter, it could be in the liver, and where it can cause a further injury. So ideal position of the UVC is in the central vein, which is inferior vena cava. And for umbilical arterial line, we have got 2 options, which is high position between T6 to T9, or low, which is below L2, L3. We just have to avoid renal arteries. So this we can confirm by doing the X-ray as well.
Umbilical have 2 arteries, 1 vein. This pictures clearly show the visible dressings with all covering umbilical catheters.
And as I was saying, see, this is the X-ray, which shows, see, there are 2 lines on the X-ray, which is on the right side. The one on the right to the spine is the umbilical venous line, which is going straight, whereas a smaller line, which is on the left side of the vertebrae, which we can see that this line has taken a dip and then gone up. So that is an umbilical arterial catheter. If we are in doubt, we always do lateral X-rays, because the lateral X-rays also confirm this position which may be sometimes confusing on the APV.
This fluid ready for umbilical arterial catheterization. Heparin, sometimes if we don't want to use heparin fluid, we can use 0.5% NS, 0.5 ml per hour. This is the care bundle we are using for central line. Use single lumen. If we want to mention the use single lumen or double lumen, we are using. Reason for catheter insertion: preterm, sick babies, and avoid femoral site. Subcutaneous vein is the preferred site, and maximal sterile barrier precautions during insertions and site of insertion. Umbilical venous umbilical catheter or umbilical artery catheter. How many pricks done, and use semi-prepared dressing. We want to observe this care bundles and maintenance care bundle each shift. Use aseptic technique for daily care and maintain closed system all the time. Review need for catheter on daily basis and remove promptly is not required. Inspect catheter on daily basis, signs of any infection is there, and flush the catheter line as per policy, and do not leave any blood stain in catheter. And we want to clean the hub with 70% alcohol before and after use. This is the important ongoing management. Observe the skin color, any branding or bluishing. If any bluishing, report immediately to doctors. Maintain infant supine or in lateral position because of observing for hemorrhage or blocking. Disinfection of catheter hub prior to flushing or administration of medicine required. Keep catheter and infusion line clear of blood as blood clots may form. Remove all air bubbles in the infusion line and catheter. Do not flush catheter quickly. Blood aspirations. Blood must not be taken from catheter dedicated for parenteral nutrition infusion unless catheter-related infection is suspected and blood culture through the line are required. Blood can be aspirated from all the venous devices when cannula insertions. When blood sample from an umbilical venous catheterization must stop the infusion. If a multi-lumen catheter inside, try to keep one lumen for sampling and others for infusions. If this is not possible, flush the catheter before sampling to avoid contaminations. Bundle care for prevention of catheter-related bloodstream infection. First one, hand hygiene, hub cleaning with antiseptic solution, use of sterile equipments, evidence of inflammation, blood and insertion site. Observe the dressing be applied correctly. If dressing dated at policy, all four sides of dressing advised correctly. Need for removal assessed. Dressing clean and dry. Is the line removed as policy? Hub clean after usage. Dressing changed after 48 hours of insertions. Post-insertion care of peripheral lines and umbilical catheter with the usage of care bundles. Most important measure to prevent health care associated infection. Thank you.
Thanks. Can take questions or further points if there's any.
Yes, somebody has a question about how much amount of normal saline and heparin is to be given.
Okay, so maybe some sort of a clarification would be needed. So how much in the sense, okay, as an infusion, so we can tell, you know.
Heparin 0.5 units per hour.
But
It's
how much of that?
1000 units per ml, that is 0.1 ml, 100 units. We want to prepare 0.1 ml heparin diluted in 9.9 ml a normal saline. 10 ml preparation contain 1 ml 10 units, and take the 2.0 ml above the solution and pour 47.5 ml NS. That is become started with 1 ml per hour.
So that's the rate, I think.
Yes.
1 ml per hour of the heparinized saline or 1 ml per hour of saline or half saline. what you have to look at when you are infusing to that pump, there shouldn't be any blood coming back. Sometimes because mostly we are using for arterial line, and because of the resistance, you may get a blood backward flow that we should avoid. If we can avoid with minimal amount of fluid, it is well and good. Otherwise, 1 ml is standard. If we are extremely preterm baby and where you don't want to give too much of fluids, we can cut it down. But there is always balance whether you want the less fluid or a blockage of the line. So 0.5 to 1 ml per hour, if that answers the question.
Dr. Amish Vora, you want to say something?
I think you have to unmute him. His looks like muted. He has to unmute some. I'll try Dr. Amish to unmute.
Okay, yeah. Thank you. Thank you for unmuting me. So, yeah. So I think it's a very well said presentation by both. And really, first, Nita and Linu and Suresh have given us a very comprehensive care of preterm and term babies in our NICU. And if I may just summarize, starting with Nita. Nita gave us a very nice understanding of what we should be doing in NICU for a good development of the babies. No longer the mortality is a marker of how good the NICU is. Nowadays, most of the good NICUs in India have a very low mortality. And the important fact which is coming up now is the morbidity. And the morbidity is more we are worried about is the developmental outcome. And that
So we cannot hear you.
Yes, she said about the pain, sound, and the light. I think those three things are very important and very well understood by our nurses. And our nurses have lots of control over that. And the most important thing in NICU, it is important that the nurses take control over that. And we empower our nurses to make sure they control it. So that's the main thing. About the light, we see that people put on the light, make the patient wear the blinds when they're on phototherapy. But they don't do it in the preterm babies when they have the sleep time. So I think it's very important, as Neetu was saying, to make sure that babies, when they are stable, have their sleep time, have a day and night pattern, as she was trying to say. Okay. So Nita, do you want to give some more idea about sleep time and light time? What else you want to say? There was one question mentioning about that.
So basically, this developmentally supportive care is nowadays is need based. We have to see each and every baby. We have to assess what the need is. Say this baby is active, alert, awake now. So this is a time that we provide daylight kind of, office light kind of thing if the baby is more than 28 weeks. Now baby is sleeping. We should be putting all the light off. And it is better if we can develop this daylight, may you have the office light, and in the night you dim all the light of the NICU and only the lights which are on the chart area or the nurses area are lit so that they can work. So this will lead to a circadian rhythm development, hormonal. We know that our hormones are dependent on the day-night rhythm, and that will help. Also, if you need a procedure, don't let all the light of the NICU. Just to use the focus light for that procedure, that baby, and then take it away. So this is how can you maintain the lighting of the baby. And as we said, we should always have indirect lights for the babies. No direct light of the baby's face. Also, it is a better idea to just put a shield on the baby's eyes, like we used to put during therapy.
Yeah. So I feel that eye shield role is also there in premature and term babies when they have the quiet time. Sadly, in India, we do not have the incubators so much. But as we all are trained from Australia and UK, we practice all our babies less than 26, 28 weeks go in an incubator. And all the incubators are shielded with a cover. And so it makes our own bed, own time for the child. So, and the time is strictly controlled. What time the child is approached with the sound. Nita, you mentioned very nicely about mobile and having a typical mobile policy. Now, what is the mobile policy you want people to accept?
Sir, I would definitely recommend no mobile inside the NICU. No telephone inside the NICU. It should be away from the NICU in some office areas, and no telephone should be buzzing around all the time. No mobile should be inside NICU both ways. Sound also infection control, because mobile we are using 24/7, touching our all kind of hands in the mobile, and then we touch the mobile inside the NICU. We do not go outside again, wash our hand. So no mobile in NICU from my side. So I would recommend that.
Excellent. I think this is a very well and it's very well practiced. Like we know that all the nurses are not allowed to carry their mobiles into NICU. That is a standardized practice. But the important thing is that the doctors, when the doctors step in, the consultants step in, it's important that all consultants keep their mobile on mute before they hand wash. So it is a practice where it happens. It was a very good thing in our NICU. Any consultant's mobile rings in the NICU, he has to go and buy cake for everyone. So, that way the consultants will remember that he or she has to make the mobile silent. There was one more question. Somebody was asking, how can you get the breast milk smell in the baby inside?
So what I recommend, so from day one itself, I ask all the mothers whether the baby is feeding, non-feeding, the baby is in an NICU, not an NICU, you express your milk and send into an NICU. Maybe initial 1, 2, 3 days, the amount will be less. It is the colostrum. You can even express in the syringes and send. And then we put a vati of that milk just bedside, just at the bedside, at the head end of the baby. So the smell of the breast milk goes to the baby and they can have the feel of mother. Second thing, if the mothers are using breast pads for the excessive milk which is coming out, you can put that also with the beside the baby. Breast milk is best for the baby and it is going to help the babies in simulating the olfaction which they are already exposed inside the environment. We know that breast milk and areola smell as same as the amniotic fluid. So that is the way you can simulate the same environment for the baby. And it will give mother also a good feeling that I am able to do something for my baby, that which is very, very important to involve mothers and fathers in the care of the baby, provide them that confidence.
So very important point just to highlight what Neeta is saying is breast pads. All our mothers wear bras. When they are sleeping, please tell the preterm mothers to please put breast pads inside the bras and please carry it. Rest all things we can do or not. This is a very minimal small things which I feel has to be universally accepted and that smell has to be gone. And another important point, as Dr. Neeta mentioned, is the day and night pattern. For your stable babies, even during the day, make sure they have an afternoon nap of 12 to 4, 12 to 3, where the babies are not disturbed. And this all are tightly controlled by the nurses. So very well said. One last question before we come to your team, Suresh. Neeta, they asked about oil massage. Do you want to clarify? Because I know you said no oil massage in NICU, but you should want to clarify this to the...
So this is actually a debatable topic whether to massage inside the NICU or not, because they are study. I think SAN has done a study that they can apply oil and there was a good growth pattern. They are study done in, I think, Lady Harding also, which shared that the oil massage has a good growth pattern. So if you have good nurses ratio, you can maintain the sterility, providing a gentle, applying gentle oil, coconut oil only, which we recommend here in the tropical country, which is best suited for the baby's skin, is recommended. But we have to just see whether this practice is feasible in our unit or not. Because if there is no known harm, it is even good for the babies if you apply massage, because growth pattern are good. You can simulate, you can give positive test to the baby. And post discharge, so we always recommend.
As Dr. Neeta says, rightly debatable. We have two institutes in India who are using it. Let the Neonatal Forum or the IAP come out with the guidelines. But at present, please follow your local policy and process. With that, thank you, Dr. Neeta, really well presented. And now, Suresh, with your team, there was this question which was there. Can you mute the other people, please? Sir, Neeli D'Souza, can you mute her, please?
Done. Please go ahead.
Yeah, thank you.
Yeah.
So excellent presented, Linu sister and Suresh from your team about the central line. And the question which was coming up, which you already answered, is the one was about the heparin, how to present the heparin. And other question which people were asking is the policy. Where you get the policy for the care of the bundle? Somebody wanted a PDF copy. If you can just guide them how to get it online, sister, how do you get it? So they can help them to send the policy.
Okay.
Now, very important fact you have mentioned, one of the most important fact in your care bundle which you mentioned is your number of assistants. And it's very important that when we are taking a care of putting a procedure, it has been proven that as long as you have proper assistant, the procedures go faster and smoother. And often we are left in our own busy NICU, often we are left with one registrar or one consultant doing the line alone with the help of a sister, or sometimes the sister scrub in. So it's very important that that message should come that the sisters are also trained to be an assistant and the sisters know what exactly the role is. One of the important role which I feel nowadays is coming up in lots of center is what you rightly mentioned is getting an X-ray done before you start using inotropic drugs. But for all the lines, what we have and a lot of institutes are doing is bedside ultrasound. So our nurses help us a lot in making sure that the ultrasound windows is not frozen or the depth is proper. So those two buttons, the nurses help us when we are just trying to make sure that the positioning of the lines are proper. So that was a very well presented about the lines and about the care bundle. And most important, I think what you mentioned about is wiping the hub. I think the wiping of the hub and counting 20 rubs of the hub is a very important before you break open a central line. Second thing, what I would really like to highlight is when you're breaking open the central line, you mentioned that you have to be sterile. And that is important that you wear a sterile gloves or wear the transparent sterile gloves. So nowadays you have economical transparent sterile gloves, which you can buy it easily and use that when you're accessing any central line. Other thing I would like to mention is, Suresh, I don't know but what percentage of chlorhexidine do you use?
70% of chlorine.
His chlorhexidine, he's asking.
70% alcohol people know, but the mistakes people make is they use the adult or the pediatric 4% chlorhexidine.
Yeah, 2.5% we are using.
Yeah, so it should be 2 or less. Do not to use that 4% chlorhexidine which is used in OTs. So that is just a minor point which we need to highlight. Otherwise, I think that there was a very well presented and very well understood and very well practiced. Other thing which I often do in our unit is that we have very standardized when we put UVC, UAC. UAC always comes on the left side of the baby. Unless, so it becomes a standard care that everybody knows that UAC is always on the left, UVC is always taped on the right. So that is something which you might take from that. Apart from that, I think it was very well presented. Any points, B2 or Suresh?
I think still there is one question. Actually, it's a very relevant question and it is very practical. People, because not all centers use heparin. So somebody twice it has been asked, like, when will you give heparin? What is the dose? See, and we have had this long time ago because of the standard heparin. It comes in 2 different preparations. So if you don't dilute the heparin correctly, you may end up giving overdosages. So this is so important that at times, right now, because our nurses are well trained, we are giving heparin, but sometimes if you are not very sure, you better just go with the continuous normal saline. If you are not very sure that the dilution of the heparin is not going to be appropriate. So because we want to keep the line open, that's why I want to give heparin infusion. But if you are not very sure, because there are central pharmacies where they make TPN and they are so precise. So if you have got your own nurses, laminar flow and all those calculations are ready, then only you go for heparin. Otherwise, there are chances that if there is an improper dilution, either there could be bleeding, or if it is a under strength solution, then there are chances of clotting. So yes, to answer that question, when will you give heparin? When I want the line to be remaining patent for longer time, and when our nursing staff has been confident of having a proper dilution, and there are 2 people checking and cross-checking the dilution, then only you go ahead with the heparin saline for patency, mainly for those arterial veins.
Excellent. Over to you all, Jaisal and Ashish.
Yeah. Thank you so much, Dr. Amish, for summarizing it so well and giving us key practical insights as to what has been practiced in the NICU. I also thank Dr. Suresh and Sister Linu for excellent presentation and talk. They made the UVC line insertion, PICC line insertion in the care very crystal clear. Thank you so much. And thank you so much for answering those questions and taking your time. And thank you, Dr. Neetu. It was a wonderful presentation with covering neurodevelopmental supportive care, and it's more and more important nowadays to practice neurodevelopmental supportive care, because you are finally looking at the long-term outcome of the baby and not just the short-term outcome. So that was also a great presentation. So thank you all the panelists, and I thank the expert for being here for this webinar. And I also like to thank all the viewers for participating and being interactive and asking so many questions. Thank you so much. So for next time, we have a similar session on the 30th of September. So it will be between 4 to 5. So we'll again have one of the best speakers from Maharashtra, 2 best speakers from Maharashtra, who will be trying to educate the nurses and having a session. So thank you everyone. Thank you for joining in, and thank you for giving your time. Thank you so much.
Thanks for the opportunity, Dr. Ashish and Jaisal.
Dr. Jaisal, are you there? You want to say anything? I think
she is muted. I'll try and see if you can. I can't do it.
Yeah, I think Ghanshyam, can you unmute Dr. Jaisal?
No, thank you, everyone. Wonderful. Thank you.
Thank you, Dr. Jaisal. Thank you.
Thank you.
Okay, with this, we'll close the session now. Thank you.
Thank you, everyone.
Thanks. Bye.
Bye.
Bye.